Good morning. This is Dr. Christopher Neal. I'm an interventional neuroradiologist, a neurointerventional surgeon, and at Doctors Medical Center, co-director of the Stroke Center here. And I'm going to speak for the next few minutes about aneurysmal subarachnoid hemorrhage, critical care management with a focus on containing delayed cerebral ischemia. This is a pretty meaty lecture. It's not my usual lighthearted blow through it and oohs and ahs, so have a cup of coffee first or be wide awake. Don't try to watch this if you're about to go to sleep. Please stay with me, although it's going to seem challenging in places. It is worth getting to the far side. I have no disclaimers, no financial interests in any of the things we're going to chat about, so let's move on. Delayed cerebral ischemia, management of subarachnoid hemorrhage. This is a team sport. I rely on both the neurocritical care nurses, my angio-techs. Without them, the overall management of this case, as well as ancillary personnel you're going to see throughout this, ultrasound techs and pharmacy, and it's a complex integrated use of staff and resources, probably in a way that's not excelled anywhere else in the hospital except maybe in trauma or equaled. So let's start with a slide. Current management strategies. Let's start at the top. I'm going to try to use a pointer here. Aneurysmal subarachnoid hemorrhage. There are two primary goals. The first one is securing the aneurysm, so either clip or coil it so that it won't re-hemorrhage. Oral Nimetop for 21 days and maintain euvolemia. Frequent neurologic exams, daily transcranial Dopplers. If there is a change in neurologic status with new deficits, we tend to get a CTA and CT perfusion. If there's spasm, the spasm is aggressively managed. If there's an increase in transcranial Doppler flow velocities and they're asymptomatic, we monitor the patient carefully, maybe even increase the frequency to BID for surveillance with Doppler ultrasound. And if they're symptomatic, they certainly follow the pathway of being worked up for diminished vascular caliber and vasospasm. If it's negative, there is no vasospasm. So let's move on. Pathogenesis of cerebral vasospasm and delayed cerebral ischemia. So there are four major contributors. The first one's neuroinflammation. The second, microvascular vasospasm, as well as large vessel vasospasm. Microcirculation thrombi formation, this is often unappreciated, and cortical spreading depolarization. Most of you have at least heard or have some idea of what the first three are, but cortical spreading depolarization is likely a new concept to many of you. It's a spreading loss of ionic homeostasis with altered vascular response, change in synaptic architecture, and depression of electrical activity following a neurologic injury. Think of it in a sort of big picture way as the reverse of a seizure. You're not getting propagation out of an abnormal neuronal discharge. You're not getting anything at all, or not what you should, and it's disruptive. There's disruption in the glutamate-induced effect on ion channels. It's associated with diminished nitrous oxide. Nitrous oxide is a very potent vasodilator. So if there is any vasodilatation, there's no blood flow and other vasodilatory factors. Once again, it's associated with diminished nitrous oxide and other vasodilators. And treatment is directed at the endpoints at containing methyl deaspartate antagonists and other ion receptors. So this is a complex slide. We're going to take a few minutes and work through it in a logical fashion. And then I'm going to take the next few minutes after this and try to tie all these what appear to be different things, totally different processes together. So the initial event is the aneurysm rupture. So the first physiologic response is increased intracranial pressure and decreased cerebral blood flow, both of which then contribute to global cerebral ischemia and secondary brain edema because you have inadequate perfusion. All of these things contribute to acute hypertension, the Cushing reflex, trying to change these other things, and disruption of the blood-brain barrier from the combination of all these factors. Right down the middle you have a blood clot, which is the blood that's leaked into the subarachnoid space. All the subarachnoid hemorrhage contributes to inflammation on the surface of the brain and actually in the brain parenchyma itself. I think the best way to think about this is to think as subarachnoid blood is like having acid poured on the brain. The brain gets really unhappy when you put blood on it. Think about it. Someone comes in with a CAT scan and they have 2 or 3 cc's of blood in the subarachnoid space. You may not be able to see it very well on the CT scan, and they have the worst headache of their life. So the blood clot also starts the electrophysiologic pathology or pathophysiology of cortical spreading depression. The inflammatory process, endothelial cell death, all contribute to vasospasm, microcirculatory dysfunction, which is spasm of small vessels. It's not difficult to understand when small arterial vessels are diminished in caliber in the presence of triggered clotting cascades. They also clot or embolize. You end up with cerebral ischemia. The final common pathway is apoptosis or cell death with secondary neuronal generation, and you end up with an infarct. In a patchy fashion, not like you would see from a large vessel occlusion and ischemic stroke, a large vessel ischemic stroke. The correlation of this is you end up with neurobehavioral deficits of everything imaginable. So let's address those a little bit. There are some specific findings. Frontal lobe neurobehavioral deficits include diminished motor functioning. There's planning and initiation of motor behavior which is altered. Speech becomes altered. Executive functioning, judgment, planning, decision-making are frontal lobe functions. Verbal and design fluency are frontal lobe functions. Clearly the frontal lobe, the posterior segments of it, and inferior tied to the limbic system, so you have some emotional functioning and in many cases lability. Temporal lobe dysfunction is often associated with perception of auditory information being altered, pattern recognition, facial recognition being altered, memory retrieval. The hippocampal formation is the seat of memory. Acquisition of new declarative knowledge, again, the seat of learning and retention is the Ammon's horn area in the hippocampal formation. And then you have acquisition and expression of emotional memory. These things are, again, all tied into the anterior fornix and part of the amygdala, which is tied to the limbic system. Other cortices include the occipital cortex, which controls vision, the precentral and postcentral gyrus for somatosensory perception, touch, vibration, temperature, proprioception, visual spatial processing. In the posterior fossa, the cerebellum, unknown to many of us, does control some fine motor movement. Think of a Parkinson's patient with a pill-rolling tremor. That is a supranuclear finding, but that's the kind of fine motor loss of coordination, although it's a supratentorial inciting event, it's metered through the cerebellum. There's gait disturbance, which is from the cerebellum, and motor learning. Eye movement is completely controlled, not so much by the cerebellum, but by the structures in the posterior fossa, the medial longitudinal fasciculus, and the descending tracts and the pontomesencephalic junction. Eye movement and its coordination. Speech also has some input, and orientation of attentional resources, so sort of waking up and being tied to the autonomic system. All right, this is a really busy slide, so before you panic, let's slow down and take this just one piece at a time. We're going to start in the upper left-hand corner, and here again we have our box which says acute subarachnoid hemorrhage. Now we have a bleed. So the first thing we're going to look at are mechanical effects. So the clot takes up space inside the brain. Here's the cartoon showing this. There's brain tissue destruction directly by the hemorrhage. There's mass effect, which causes all kinds of problems, including the ICP being elevated. Blood that makes it into the ventricular system. Remember, this is part of our Fisher-Kistler grading. Contributes to hydrocephalus. 20% of all subarachnoid aneurysmal subarachnoid patients require permanent ventricular shunting. All of these things cause early brain injury, blood-brain barrier disruption, cerebral edema, endothelial cell apoptosis, and then you have the phagocytic stage of trying to clear this all up. Global ischemia from the acute subarachnoid hemorrhage causes a diminished cerebral blood flow secondary to high ICP. Again, hydrocephalus due to microcirculatory compromise and, as we discussed a few minutes ago, microthrombosis. At the cellular level, here we are at the cellular level. These are microscopic changes. We have diminished nitrous oxide. Remember, this is a vasodilator. When it's not there, blood flow diminishes. There's an increase in extracellular potassium. Remember, normally if we draw potassium on a patient, their sodium is high, their potassium is low, but inside of every cell in your body, it's the reverse. So when you have cell death or the ion pump is altered, your extracellular potassium is elevated. There's oxidative stress, increased endothelin-1, inflammatory processes, which is a cascade of cytokines, chemokines, proteases, an entire complex matrix of apoptotic pathways, and these are associated also with platelet aggregation and activation, which causes clot, again diminishing flow, ATP depletion, and thrombin activation. Systemic complications from global ischemia. You get the sympathetic nervous system triggered, and we see neurogenic pulmonary edema, stunned myocardium, tachysubocardiomyopathies, also known as a broken heart syndrome, ECG changes, ectopy, hyponatremia, and severe inflammatory response syndrome. This is an even busier slide. One more time, we're going to break this into multiple slides. Don't try to chew this all down at once. I want you to get a big picture of what's happening. So let's go back to our subarachnoid hemorrhage. One of the first things to happen is the posterior hypothalamus becomes ischemic because of its location in the brain. This causes an increase in circulating catechols, antidiuretic hormone. The body tries to retain fluid. You get water retention, hyponatremia. The catechols cause myocardial disruption, left ventricular dysfunction, particularly diastolic dysfunction, and dysrhythmias. This both can precipitate syncope and pulmonary edema. The hyponatremia blood breakdown as the blood falls apart within the subarachnoid space. It releases epileptogenic products into the cerebral circulation. There's spasmogens, cerebral vasospasm, creating hypoperfusion, and an altered catabolic state. Bleeding into the subarachnoid space directly obstructs CSF flow and its normal circulation. The Paconian granulation, subarachnoid granules get plugged, often by red cell ghosts. As the cells lyse, they discharge the hemoglobin and it lyses from the cell, and you have these cluster of cell membranes which have to be phagocytized and removed, but in the interim they can plug the filter, which can contribute to hydrocephalus. You get distal vasodilatation. There's a sudden increase in blood volume in fixed space. They get the thunderclap headache. Blood breakdown products in the CSF percolate sometimes for weeks. They irritate the meninges. It is not uncommon to have a patient who refuses to get out of bed and exercise or do anything 8, 10, 12 days after subarachnoid bleed to get severe lower back pain. The breakdown products of the blood liquefy, drip down through the foramen magnum, sink to the bottom of your thecal sac at your lumbar spine, and I sometimes have to put people on steroids to get this turned around. There are some specific mechanisms. Posterior communicating artery for presentation. These are things you might think about, some of you may know. Don't try to memorize this. They're big picture things. We have a patient recently, posterior communicating artery aneurysm. They show up with a central third nerve palsy, ptosis of the affected eye, and a blown pupil. They often get medial gaze palsy, diplopia, and a non-reactive pupil. Anterior cerebral artery, these are probably the most complex in terms of clinical presentation. They can get motor strip ischemia, bilateral leg weakness, and avolition. Middle cerebral artery ruptures are often associated with hemiparesis and neglect. Internal carotid aneurysms are often associated with pituitary ischemia. So here we are. This is the posterior hypothalamus. I just want to show you where it is. This is a cross section of the brain. This is the corpus callosum where the arrow is. This is frontal lobe. And so this is the sella turcica right here. Here's the hypothalamus where the nucleus posterior, the sulcus hypothalamus. So in the posterior hypothalamus is the sort of mediator for many of these problems. The blood sits right down here in the suprasellar cistern and irritates this structure. Artery-specific mechanisms I mentioned a minute ago. We're going to go back and look at these real quickly. Once again, posterior communicating artery aneurysms. They sit on the third nerve. There's compression and irritation because the aneurysm blows and blood is discharged right onto the third nerve. Almost always have a non-reactive pupil, often have diplopia, and usually have ptosis. Anterior cerebral artery injuries, in this strip up here, frontal lobe ischemia, avolition, they often have lower extremity weakness, which is diffuse and often not appreciated until rehab is attempted. Middle cerebral artery ruptures out in here can cause motor strip issues and parietal association issues with aphasia and neglect. So let's come back down to earth and things that you do every day. So the aneurysm status, pre and post securing, member treatment, pharmacology, intracranial pressure control, osmotic therapy, hemoglobin, fluid status, pneumotop, things to avoid. Sort of an outline. The things to avoid. Forget the rest of this slide. What you don't want. If you can't remember anything else, you try to avoid hypoglycemia. Keep the patient euvolemic to maybe hypervolemic. You want their temperature normal, their oxygen and carbon dioxide levels normal, and their magnesium normal. Monitoring for cerebral vasospasm. We're going to shift gears a little bit and monitor for things for a second. There are various mechanisms and studies we can do for this. There's transcranial Doppler ultrasound, which we do at this institution every day. It should be done from the first day of admission if possible for a baseline. Continuous electroencephalography, we do not have this yet, but I see it being added to our armamentarium in the near future. We'll get to that in a minute. CT is a great problem-solving tool, but not good for day-to-day usage. Same with CT arteriography. MRI is most sensitive for detection of early delayed cerebral ischemia with restricted diffusion, which may be reversible. And MRA pretty much follows the same function as CTA. Perfusion scanning with the more modern CT scanners may be of some use. So transcranial Doppler ultrasound. To those of you who work in the ICU, they see this done every day. I'm going to go over a couple of just key pearls and points here. Normal velocity should be less than 100. You can be up to 120 and still be normal. Mild to moderate spasm is 120 to 200. Anything over 200 is severe. All the studies done to look at how this works have only documented that middle cerebral artery data are reliable. In other words, if you have an abnormal velocity in an anterior cerebral artery or posterior cerebral artery, we don't know that it necessarily means it's really significant, although we certainly pay attention to it and evaluate the patient independently. Probably one of the things that's most important are the serial numbers. There are patients who are normal that are in the 120 range or 130 range. There are other patients that are normal at 30 and very abnormal at 60. So one of the reasons to establish a baseline is to have some idea of what that patient's normal is before they end up in trouble 4 or 5 days later. Vasospasm usually doesn't set in with symptoms till at least 72 hours after a rupture of an aneurysm, and it has been seen as late as 5 or 6 weeks, but most patients present within the first 14 days. The Linegard ratio. So The Lindegaard ratio is a ratio that's applied to the transcranial Doppler ultrasound data. And if you take the mean velocity in the middle cerebral artery over the mean velocity in the internal carotid artery on the same side, you end up with a ratio. High middle cerebral artery velocities may be due to hyperemia or vasospasm, but the Lindegaard ratio differentiates the two. The accuracy is 90% for detection of vasospasm. So in patients that have an elevated flow velocity, we calculate the Lindegaard ratio. If it's greater than 3, they're felt to be positive for spasm. Greater than 6 is severe. There is a similar process for the basilar artery. I'm not going to get into it in this talk, but it's a separate measurement. Ultrasound images of vasospasm. So this is what it looks like on the ultrasound machine. And here you see normal waveform morphology and spectral during the heartbeat, and the normal waveform decay, and you've got a spike and then a gradual drop. In spasm, there's a sharp peak up and then a broad the spectrum is broadened here compared to here. And so there is spectral broadening, and this vessel appears to have a shorter interval. It's because this is stretched out. You can actually hear this when you hear the technologist doing it or you do it yourself. So in this particular graph or image, you can see the velocity is 62 centimeters per second. We just said that was normal. It's less than 100. And in this one, it's 201, which is clearly over 200 and abnormal, assuming the Lindegaard ratio is high, and it was in this patient. It was over 7. So this is a classic image for vasospasm on ultrasound. A couple of months ago, landmark paper in neurology by Chen et al., transcranial Doppler and EEG combined, this is continuous EEG, are better predictors of DCI after subarachnoid hemorrhage. My suspicion is we'll need to soon add continuous EEG in our ICU as a monitoring tool. Management strategies. So now we're talking about treatment. What do we do to help these patients and keep them from getting delayed cerebral ischemia and permanent neurologic and behavioral injuries? The first is to keep their blood pressure before the aneurysm is secured low. I actually like it much lower than 160. I'd like it as low as they'll still stay awake and not pass out. The lower you keep the pressure, the lower the pressure head in the aneurysm is, the less likely it is to bleed. Once the aneurysm is secured, the growing body of information suggests you should keep the patient normotensive and let them autoregulate their blood pressure. If they're normally hypertensive, I would treat it to keep them within normal range. Blood pressure control drugs, our favorite 3 are nicardipine, labetalol, and clofidipine. Clofidipine is a newer calcium channel blocker in the same class as nicardipine. It has the same utilization and safety profile. It has a little more rapid onset of action and a little more rapid tapering of action. So if you turn it on and off, you have a little more tighter control of their blood pressure. Next, osmotic therapy or EVD for intracranial pressure control. We often place CSF derivation with a ventricular drainage catheter for patients with severe hydrocephalus. Osmotic therapy, mannitol gives you very quick control of the ICP. If you have to change somebody's ICP in a hurry, mannitol and steroids often work well. You have more detailed control with hypertonic saline, but it takes a while to kick in. Hemoglobin, we want their hemoglobin normal. Fluid status, remember, at least euvolemic. Calcium channel blockers, we use nimodipine. The first dose should be within 24 hours of arrival. I'm going to get back to the beginning of this where I said the things to avoid. Avoid hypoglycemia, dehydration, fever, hypoxia, hypocarbia, and hypomagnesemia. So, optimization of fluid status and hemodynamics. Prophylactic Triple H therapy, which had been a mainstay for this for years, has been shown to have no effect on prevention of cerebral vasospasm. I'm going to say this again. I get asked this at least once a week. prophylactic Triple H therapy in a patient who is not in spasm is not helpful in prevention for cerebral vasospasm. Keep them normal tensive. You want to optimize the cerebral perfusion pressure and keep them euvolemic. Induced hypertension for vasospasm treatment is a different story. Induced hypertension in symptomatic, that means patients who have vasospasm symptoms, euvolemic patients, is currently recommended and shown to reduce vasospasm in up to 2/3 of patients. That means both vasospasm as an entity and the damage done by vasospasm. Drug of choice is phenylephrine and norepinephrine. I prefer phenylephrine because it's pretty clean, and they're absolutely the safest in patients with normal LV function. Dopamine should be meticulously avoided. It has cardiac issues, particularly to do with ectopy, but more importantly for us, it increases the ICP. There are other drugs. Milrinone may be soon put into use here. It's still being studied. Milrinone phosphodiesterase has been shown to diminish the need for endovascular interventions, improve outcome, and some suggestion improvement in cognitive function with diminished incidence of concomitant cardiac and pulmonary complications. There are no randomized trials yet to support the superiority of any of these drugs, one over the other. So they're all used based on a given patient's presentation and need. Hemoglobin. 40 to 50% of subarachnoid hemorrhage patients develop anemia while in the ICU. They get blood drawn every day, sometimes multiple times a day. Anemia is an independent negative prognostic indicator. It's associated with increased morbidity all by itself. So I think often we don't pay that much attention to it, but patients with poor outcomes have consistently low hemoglobin between days 6 to 11 from the mechanism I just gave you, which is concomitant with the highest prevalence of delayed cerebral ischemia, vasospasm, and secondary cardiac issues, probably from the low hemoglobin as much as anything else. So patients who have an unusually low hemoglobin, we should have a low threshold for transfusion consideration. Calcium channel antagonists are a mainstay of therapy. Nimodipine is the only agent shown to reduce delayed cerebral ischemia and improve outcome. The evidence level is class 1, level of evidence A. That's as good as any study gets scientifically. It has a neuroprotectant effect and decreases cell death by reducing intracellular influx of calcium. Leptomeningeal arterial dilatation may decrease delayed cerebral ischemia, or at least that's currently postulated. And this probably has an antiplatelet aggregation effect, again, likely because of improvement in cerebral blood flow and not directly on the platelets themselves, but complement and other cascades may be inhibited. Indications. So nimodipine should be given as a background. Endovascular management of vasospasm should be used when medical management's failed or the risk-benefit ratio is being altered. So there are a couple of different ways we can treat the patient by taking them down to the neurointerventional surgical suite. Intra-arterial calcium channel blockers have a very long safety profile. They're very efficacious. They take a long time to administer, and sometimes the patient's down for several hours. Mechanical treatment with either balloon angioplasty works well for patients who have definite spasm, but not for prophylaxis. And I actually think mechanical angioplasty today is being spearheaded with stent retrievers, which are safer, I think have a better safety profile than balloons. Timing, you want to make sure that patient's treated before the stroke becomes complete. So the minute they get severe ischemia, they should go to the lab that day, not the next morning, not 15 hours later. If they show symptoms of an abnormal ultrasound or abnormal clinical picture, they should be taken to the lab that day, hopefully as soon as you can get them downstairs. This is a single random image of a patient that I treated with coils, and you can see there's spasm in this artery here and here. This is post-treatment. You can see the arteries back open. This is after intraarterial infusion of a calcium channel blocker. Pharmacologic and arterial dilatation therapy. So let's take a quick look at what's out there. This is just a fast review. Papaverin has a historic reference. We don't use it now. It's very complex to give. Works on cyclic AMP and GMP. It's very, you cannot mix it with heparin or you get precipitation of papaverin crystals, which cause microemboli. It has lots of other drug interaction problems, and it has irregular use. It was one of the first drugs we used, and it doesn't work very well, and it's been long abandoned. It also increases intracranial pressure. Nicardipine has been a mainstay of therapy in the United States. We do not have nimodipine in the U.S. in a parenteral form, but that's used in Europe and most of Asia. Verapamil works very well. I prefer nicardipine for a number of reasons. It has the same effect as verapamil. It may have a longer lasting action. It has to be given a little more slowly. It increases myocardial oxygen extraction without increasing the workload of the heart. So it has a significant cardioprotective effect in these patients who get catecholamine-induced MIs and tachypseudocardiomyopathies. And here we are trying to beat on their heart to keep their pressure up. Many of these patients have underlying coronary disease. So it has a very significant cardioprotective effect that none of the rest of these drugs have. Milrinone, as I said, we don't have yet in the U.S. Fasudil is not available here yet. So just a quick, I know you're not in organic chemistry, but let's take a 2-second look at why these work. Here's the functional central portion of the molecule. And if you look at nicardipine, there's a aromatic nitrile side group over here, and then a carboxy acid on this side to make it soluble. But nimodipine crosses the blood-brain barrier because there is no ion branch. There's some polar portions to the molecule, but this is just an ethyl branch, and even though there's a polar oxygen here, it's not a salt or an ion. So this crosses the blood-brain barrier a little better than nicardipine. So let's take a look. This is a case of severe vasospasm. This is before treatment. Notice these big vessels. This middle cerebral artery is skinny down to much smaller than it should be. It should be 2.5 to 3 millimeters, not much smaller than this, and yet it's in spasm. You can see the lenticular striates, this tiny anterior temporal branch, and the candelabra is spared. That's because the puddle of blood is right here causing this. You can see the coils in the aneurysm. Notice that on this first injection, that even though the catheter is in the carotid artery, there's reflux of contrast out these external carotid branches because it can't flow forward. This is after 18 milligrams of nicardipine. And you can see the vessel looks much better, and there's no longer any reflux for the same flow. I know what you're going to say. You're going to say, but Dr. Neal, that artery doesn't look very good. No, it doesn't look very good. But I'm going to take you back to Pucell's law. And blood flow is dependent on the fourth power of the radius. So if you have a 1-inch pipe and a 2-inch pipe, and you're putting a gallon of water a minute through the 1-inch pipe, and the pressure, temperature, viscosity, everything stays the same, the 2-inch pipe gets 16 gallons a minute. What does this mean? Very small changes in caliber are huge changes in flow velocity and rate. And for all of you who are thinking about this, think about the difference in flow in an IV between a 20 gauge IV and an 18. They aren't that different in size, but there's a huge difference in how much flow goes through an 18 over a 20. So mechanical angioplasty. We use either a stent retriever or balloons. I think stent retrievers are much easier. I actually don't have to put the patient to sleep. There are compliant and non-compliant balloons. There is a low level of evidence for benefit. Probably most importantly, there have been several studies done on asymptomatic patients with multiple deaths from balloon angioplasty. And I think it's underreported. So it's a very dangerous treatment that we only pull out if we need to. I do think stent retriever angioplasty is far safer. There is a large trial currently underway. I think it's being altered because of the addition of stent retrievers, so the data may not be out for a bit. So here's a case. One we just showed you. Here's a high-grade stenosis. This picture shows the stent retriever in place, and same, you're like, I think you're making this up. But here's a magnified image. So here's the aneurysm coils. You can look at the stent retriever's open. It's widely open, widely open, widely open. It doesn't quite open all the way out here. Here's the lateral view. Notice that the carotid terminus, which to me is critical, has the stent retriever across it. We're angioplasting both the carotid terminus, the M1 segment out to the M1-2 segment junction. And here's the pre and post. That treatment took about 90 seconds. And the artery looks much, much better in a very short time frame. So it's not only very safe, it's very quick. Again, here's the injection in the internal carotid. You can see reflux of contrast out the external carotid because of no flow forward and reflux of contrast. Note that the catheter has actually been moved distally. It's been moved from here to here, and now there is no reflux with a brisk injection. Other surgical techniques. So there are endovascular devices. We don't use at this institution, but you should be aware they exist. The NeuroFlow catheter is a fancy device designed to go straight in the brain, so is the BrainsCape. Inaortic balloon pump was in and out of fashion a few years ago. Neurogenic hyperthermia, I don't know that that works, especially it's been reported in Japan. It's not used in the United States. Intrathecal administration of drugs. This actually has a huge amount of benefit in a small number of patients. Nicardipine instilled directly into the thecal space through a ventriculostomy catheter works really, really well in treating vasospasm. Many of our patients don't have an EVD in, but it's reasonable to try it at the bedside. Using thrombolytics to dissolve clot interventrically after the EVD has been in place at least 72 hours is also used in many institutions. I haven't had an opportunity to use it here yet, but it's something that's always in the back of my mind. We can offer these things to patients that fit the treatment paradigm. Lumbar drainage has been suggested for marked improved outcomes in diminished vasospasm. There is a lumbar drainage trial being done internationally now. The results aren't in. The early drain is an early lumbar CSF drain and aneurysmal hemorrhage currently underway. We are not part of the study, but as soon as the results are out, if it's positive, I'm sure you'll hear about it. Kinetic therapy. This is a great thought. I'm not sure this works very well. The theory is principal clearing of blood from the CSF with the help of mechanical agitation. So I think of this as the voodoo shaker versus the hula head technique, where the patient's head is continuously manipulated like a washing machine back and forth to try to knock this loose. I'm not sure this will ever be in vogue. A couple of words about heparin. Heparin's a silver bullet. Low-dose intravenous heparin has been associated with both a decrease in cerebral vasospasm and delayed neurologic deficit, contributing to improved neurologic outcomes. It has some anti-inflammatory effect, which is poorly understood. It does bind to oxidized hemoglobin, a major culprit in vasospasm induction, and it inhibits messenger RNA transcription of endothelin-1, which suppresses smooth muscle hyperplasia. Smooth muscle hyperplasia, of course, makes vessels small. You get vasoconstrictive ischemia and progressive injury, so these are sort of tied together. Other modalities in process and works in progress. Endothelin-1 agonists, clazosentan is not used. It's a very potent vasoconstrictor. Studies are being done now, but so far no outcome differentials. Magnesium inhibits voltage-dependent calcium channels. There's no data to support routine use of excessive IV treatment therapy, but we must keep their levels normal. And in my opinion, this means the upper to mid-range of normal. So at our hospital, if you're less than 2 milligrams, you get a transfusion that day. I had a patient last week I treated a second time in the same day because they were retested and still below 2. Statins have tremendous anti-inflammatory drug effect. I think their big picture of long-term beneficial effects are just now being realized. But at the moment, they're being shown to have conflicting benefit in multiple trials. No clear indication for routine use, but individual patients may clearly be given these drugs with a high degree of benefit. Direct interruption of biologic pathways. There are theoretical treatments, erythropoietin to increase tissue oxygenation, Tyrolizat and nicardipine are hydroxyl-free radical scavengers. There is an extended release form of nicardipine. Sildenafil, known to most of you as Viagra, is a 5-phosphodiesterase inhibitor, inhibits cyclic GMP and causes vasodilatation. I have actually used this in parenteral form on several patients, not at this institution, but in refractory spasm elsewhere and for prophylaxis, and it does work, but it's not routinely used. Interestingly, in my experience, it's worked better in women than men. Thrombolytics, we just mentioned this, clearance of blood products from the ventricular system. We can certainly consider placing thrombolytic down the EVD, clamping it, and then letting it redrain. So protocol-based management, which is what we have here, this is just a representative image of a form that has all of these processes laid out as a nursing order chart and form. But following protocols and is an ongoing process, and so our protocols today will evolve over time as things improve, and outcomes are proven either within our own institution or at the national and international level. So in summary, subarachnoid hemorrhage with consequent delayed cerebral ischemia can only be successfully managed in highly experienced centers to optimize global outcomes. The comprehensive, complex, systemic compromises and stressors require not just judicious management, but continued clinical reassessment for improved outcomes and treatment therapies. And I thank all of you for sticking with me in this very meaty, challenging discussion. Thank you.